name is Dr. Robert Rahimi. I'm a clinical associate professor at Baylor University Medical Center. And I'm here to talk about hepatic encephalopathy, what the current treatment options are, the pathophysiology, as well as combination therapies. So what is hepatic encephalopathy? It's actually a neurocognitive disease, but it's reversible. And it's in patients that have chronic liver disease or cirrhosis. And there's two different types. There's covert, which basically means it's minimal hepatic encephalopathy, little confusion, but there is also overt or acute encephalopathy or acute confusion. A lot of studies have looked into many factors that are involved in hepatic encephalopathy. One of them is ammonia. And the reason this becomes important is because we target the therapies with ammonia reducing treatments. One of them will be lactulose. And the reason that becomes important is because when we eat or drink anything that has protein, the gut microbiome or the stomach breaks down our food and the byproduct ends up being ammonia. Ammonia is actually toxic to the brain. And in patients with chronic liver disease or cirrhosis, they can't break down that ammonia. So what happens is it ends up going into the blood, it ends up going into the brain, and it causes swelling of your brain cells, and that causes the confusion. So how do you treat that? When you do lactulose therapy, you can get rid of this toxin through your stool output. You take the liquid and you cause to about 2 to 4 bowel movements a day, so you excrete the ammonia through the stool. This is one of the important studies that they looked at, specifically lactulose therapy versus placebo, meaning no therapy at all. The lactulose showed a huge improvement in hepatic encephalopathy, and patients that were in the placebo group, they had twice as many more occurrences or reoccurrences of hepatic encephalopathy. If patients have failed lactulose therapy as the first standard of care, and they get readmitted to the hospital for confusion or hepatic encephalopathy, the standard of care is to add on rifaximin, which is specifically a non-absorbable antibiotic. So it's an antibiotic, but it doesn't get absorbed into your bloodstream. It stays into the gut, and it changes the ammonia into the gut as well as the gut microflora. And so that becomes important as additive therapy. There was a very seminal study in the New England Journal of Medicine where you can see with the red and blue lines here that patients that were on rifaximin versus those that received placebo, they had decreased readmission rates for hepatic encephalopathy, and overall they did better while they had lactulose on board. So this study specifically showed patients that were on lactulose therapy with additive rifaximin therapy. And there was over a 50% reduction in recurrent admissions to the hospital with confusion while taking rifaximin and continuing the lactulose therapy. So overall, additive therapy with rifaximin on top of lactulose after a patient has failed the first treatment with lactulose therapy is crucial. This off-label study looked specifically at adding rifaximin and lactulose for the first episode of overt hepatic encephalopathy. Currently, the FDA approval is not to add these together after one recurrence of encephalopathy, but this study shows that in a sicker patient population, patients that got both medicines did much better overall. So in summary, the takeaway points for hepatic encephalopathy is this is all reversible. It's a reversible cause of confusion with chronic liver disease or cirrhosis, and hepatic encephalopathy needs to be targeted with therapeutic options. The first one, standard of care, is lactulose. And then the second additive therapy after a patient has got readmitted to the hospital is to add on rifaximin. And with that, I thank you all for your attention.